Gue, welcome to the KSCS presentation of Tehontatro. This is a series of information sessions on various topics. Please watch our previously recorded episodes and keep an eye out for future sessions. Enjoy. Hi, my name is Christine Taylor. I am a prevention worker here at KSCS, and I'm also a co-coordinator of Tehontatro, which is they are sharing and telling with each other. And basically it's presentations that we schedule for people to come in to share what they're doing, information, as well as possible resources that might be helpful to our staff, but also the public is also invited to these presentations as well. Even though this is only our second time back since COVID started, so we're still ironing out a few of the bumps, and maybe we could have you back again.
Sure, definitely.
You know, with more people.
Yes.
To the presentation. But I'd like to welcome Genvieve Lavigne. She is a member. She's the lead, right?
Yes, I'm the coordinator of the program.
Coordinator of the program, which is PEP.
Yes.
And that's first episode of psychosis.
Exactly.
All right, so I'd like to welcome Genvieve, and she's going to give us information on her program, which I thought was super interesting. All right, so thank you.
Okay, well, hi, everyone. Well, as we are a small group, you know, the intention for me is that we can do this very informally. If you have any questions, you need clarification, don't hesitate. The idea is that you be able to get the information that you're looking for, and that we can discuss and participate together. So you'll have to excuse me sometimes, my French. Sometimes I look for my words in English, so I might ask for some help sometimes for the translation. So yes, as Christine said, well, first of all, thank you. I'm glad to be here. The idea is that our program, me being here today, I have two objectives. First of all is to let you guys know what the PEP program is, so that you are informed and aware of what's available in terms of services. And the second part, after I explain a bit what we do, part of our role also is to do some education with our partners, with other professionals in the community, as well as with the community, to be able to educate on what is PEP. What does that mean? PEP is, as Christine said, the first psychotic episode program. In English, like at the children, they will say the FEP, first episode of psychosis. But so that's what it refers to. So education on what is psychosis, what does it mean, how do we treat psychosis, how do we offer services that will benefit the clientele who might be experiencing such a medical problem. So I'll start. Me, as was mentioned, I'm a social worker. I work at the outpatient clinic here in Châteauguay. I'm affiliated with Anna Laverge Hospital, and basically I'm also the coordinator of the program. So I work for the CISMO, which is very long, so I'm not going to give you what it means because it's too long, but I think you guys know what it refers to. So am I going too fast, or it's okay? It's okay? Perfect. So basically, just to give an introduction, the PEP programs have been implemented in the area for about 5 years now. In the Montérégie area, we're the last ones who kind of started to be implemented in the entire territory. So we here cover from Beauharnois to Candiac, but we also offer services to the community here in Garawagi. And it's important that the population, the professionals know that we're there and why we're there, so that they can refer to us if ever they're experiencing a situation which involves psychosis. The program is geared to we're a team that works from the clinic. We work mostly in the community in the sense that it's not necessarily people come in the office and have our meetings at the office. A lot of what we do, we go out. We want to go in the community to meet them in their work environment, school environment, home environment, so that we can offer services that are adapted to the needs of the clientele. We deal with the population that it's aged from 12 to 35, which might be at the beginning of experiencing mental health problems. And the idea is when we refer to a first psychotic is that we're at the beginning, as I said. There's never been any treatment prior, or there's never been any treatment for psychosis, or they've been treated for less than a year. So the idea is we want to get involved as quickly as possible so that we can rapidly implement a treatment program that will be able to help them cope with the situation. Yeah, so basically, it's important to understand that what is psychosis. This is a word that sometimes scares people, or there might be a lot of misconceptions in terms of what psychosis is. So I'm going to give you a bit of info if you're okay with that. Ultimately, it's a very specialized program. So the idea is we're not there to replace other programs or other services that are already available in the community. But we really want to gear and try to focus on prevention and mostly being able to detect people who present clear symptoms of psychosis. So with that being said, I'm just going to give you a bit of info, and a lot of what I'm going to give you in terms of information on psychosis or the symptoms and the treatment, I've printed out some documents that are accessible, very easy to understand, where it gives you a bit of the outline of what I just mentioned or what I will present.
You want me to pass them out?
Yes, you can. That would be great. And I also brought our pamphlet. I haven't had the time to.
Oh, I'll take care of that for you.
But the pamphlets are here. And what you'll find also, of course, you have our phone numbers where you can call us. But also on that, which is also very interesting because I looked into them again this morning, and all of them are bilingual. But you also have websites that you can refer to, which are very interesting, and they're very accessible. Okay. So first of all, but what's important to say is that, yeah, do you guys have any questions so far? No? Ça va? Okay. So basically, psychosis is a serious medical condition in which a person has trouble telling the difference between what is real and what is not real. Typically with symptoms such as delusions, believing, for example, that certain things are happening which other people are not experiencing, and or hallucinations. What is important to understand is that this serious medical condition can affect up to 3% of the population. So the idea of the PEP programs, and the reason why there were funds that were brought out and these teams were put in place, is that the idea is that the sooner you intervene, the better results you will get in terms of treatment. So the longer there are risks to the fact that you don't treat rapidly psychosis, in the sense that it can have important effects on your physical condition, mental health situation, and affect various spheres of your lives, whether it be your relationship with family members, whether it be your ability to work, your ability to go to school, or even in certain situations, go through very traumatic situations, such as going to the hospital when you're not, say, when you don't want to. Again, so the idea is that we want to intervene quickly so that we can rapidly get involved to try to avoid all of these negative consequences. Our program is accessible, that being said, in the sense that we are a small team because based on the population in the area, but people can call us in terms of referrals. They can call us directly at the clinic. So what that means is that there's no waiting list, usually no waiting time. People, given I'm the coordinator, people can call me directly, and I'm the one who receives all the referrals for the PEP program, or a member of my team. So we exchange on the situation. We try to look at what's going on, and if based on the information it seems to be something that could be associated with psychosis, then we do a first contact with the client or with the person that is experiencing the symptoms of psychosis. So it's very quick. Usually we try to intervene very rapidly to avoid any delays in the treatment.
I have a question.
Yes.
So for psychosis, if a young youth is having, like, has experience with trauma and is dealing with the trauma through, like, a food addiction and is then experiencing like suicidal ideation, would that also be possible to go into like a psychosis? Is that a possible a route to that, to having a psychosis, or is that something that's completely different?
It all depends. In terms of when someone asks, for example, a lot of the clients we work with or family members, when they ask what's usually the cause, it's really a correlation. It's a combination of various factors that can lead up to having acute symptoms of psychosis. For some people, so for some people, there are a genetic aspect of it. When the family members, for example, has family history of a psychotic disorder in the family, that can be, for example, a risk factor. But in itself, it doesn't mean that everybody who has psychotic episode will have somebody in the family. It's oftentimes combined with a very high stress factor. So yes, so for example, if somebody has gone through a very traumatic experience and a high level of stress, whether it be, as you say, a specific trauma, abuse, or whether it be a death in the family, moving, coming to a new country, for example. So a high level of stress. So there can be the combination of the two, and then that leads to possible symptoms of psychosis. But there's not like a direct explanation. So it's a variety of factors that come into play. And the way we work is really in terms of trying to reduce as possible the risk factors that are in play in the situation and address what those stress factors are, and to try to diminish the consequences associated. So it's hard to say, it depends. When we refer to psychosis, there's a variety of symptoms that come into play. You will have the symptoms that are more familiar to the population, that we're more aware of as we've talked about it or seen it in our experiences. So there's the symptoms which are the hallucinations, as it was mentioned, I just mentioned before. So auditory or visual hallucination, or even our senses that are affected in the sense, and it's things that we hear or see or feel that other people are not feeling. And in terms of delusions, there are fixed and false beliefs which do not have a basis in reality. And sometimes, thinking, for example, that the CIA is trying to, is watching us and following us where we go in the community, for example. Some delusions are bizarre in the sense that they come from something that's which are strange and completely impossible. For example, believing that one is controlled by a dead person, for example. Versus there are delusions that are non-bizarre where it could be true, in the sense that if I have a client that says to me, I think the police is following me, for example, and they're watching me, right? Sometimes we have to look at, did they go through some experiences which they could have been involved with the police, or they're being, the police is trying to find them because they committed a criminal offense, for example. So sometimes it comes from something that is real, but then it takes proportions that are far greater than the initial reality from the beginning, for example. Is that so far making sense for you guys, or?
So just a further question. So is your team, are they able to assess whether, like, in that situation, because like say this client doesn't fit in any other kind of,
yeah.
They always say, well, this not the appropriate referral. And so in your situation, would they be able to assess this client if that would,
yeah,
prevention of a psychosis to happen?
That's a great question. So For the PEP program is that we have to have acute symptoms which are clear. So a variety of symptoms, manifestations that are associated with psychotic symptoms. So sometimes people start presenting some more lighter symptoms, which could be because sometimes difficulty sleeping, for example. There's other symptoms that are associated with other mental illnesses. So if it's not clear in terms of whether there are specific symptoms of psychosis, what we often will say is that people will need to refer to other programs that are already available or go through an assessment or meet a professional to be able to further evaluate the situation. So we can't, unfortunately, we cannot meet everybody that might be or could be, or we really try to gear towards detecting the ones that are presenting, very clear symptoms, because we're a small team, and so we don't replace what other professionals are already doing or other psychiatrists who are doing assessments, for example, to be able to determine what could be the issues in play. I don't know if I'm clear, in regards to that. And sometimes when people call me, I would love to see everybody. I would say, oh my God, I think I'd love to meet this person. And what we all want is that they do not get to the point where it's acute, but and that the impacts are already, we want to avoid that we get there, but there's other services that are also there, and they can really start working on that and address the issues that are at play so that it doesn't get to the point that we need to get involved, for example. I don't know if it makes any sense or if it's clear.
Because I think sometimes some family members are not aware that, they've never been diagnosed as a psychotic,
Yeah.
That, they self-assessed or diagnosed themselves with something, back then we didn't have a lot of diagnoses like we do today. So that's, I find that difficulty is when you're trying to do that, the genetic kind of, line, you don't know those answers.
Yes, it's true, definitely, for sure. So the idea is that by being aware of some of the symptoms that could be associated with it, to be able to kind of detect it and pay special attention to it without being the only focus, but just being aware, and so that it can be addressed as quickly as possible. So, yeah. Also, so as I was saying, so basically, there's other symptoms also that are associated, and sometimes they're the ones that are most difficult to see, or they're not as clear as, for example, hallucinations or delusions, or it's everything in terms of a lack of interest in things that motivated you before. But it's not just not being interested about, like, I liked hockey and I don't feel like playing hockey, but it's really like there's no feelings associated with emotions of things that are going on in their day-to-day life. So a lack of initiative, the ability to initiate something. So changes in the moods and the behaviors will also be observed usually. Yes?
I think that's what people misunderstand, I guess, is that they think psychosis means like you're manic and you're frantic, you're loud, you're...
Yes.
Whereas it can be like what you're saying, or having auditory hallucinations but trying to keep it to yourself, you're being quiet about it.
Yeah.
They associate it more with something outright where you're going to see it, where you're going to identify it, like if they're having a manic episode. Yeah,
something they oftentimes, and it's not funny, what they see in movies, and it's very flamboyant. It's something it's quite clear and evident, but it's not always. And the difficulty is that some people will present we call it in a symptom of psychosis, we call the positive symptoms. Positive symptoms is hallucinations, delusions. So it's symptoms that are added to your personality that weren't there before. And then it's not because it's good. Positive symptoms is not good. It's just an addition to who you are as a person. And then there are the negative symptoms. Negative symptoms are everything that's taken away from your general level of functioning. And that implies the fact that you have no feelings, no motivation, the irritability. Some people present the negative symptoms at the beginning are harder to detect. say, because yes, it could be associated with other variety of symptoms also. So that's why it's harder sometimes. And they're harder to treat also. Say, the treatment for psychosis often are usually with antipsychotics, so it usually helps take away the positive symptoms, but it's harder to address the negative symptoms. So that's often what's the most difficult in terms of treatment, because clients or patients or community members will say, well, it's probably the medication that's inducing that. That's why I have difficulty. I feel tired. I can't do my things and everything. But it's not necessarily associated with the medication. It's associated also with the symptoms of psychosis. And that's what's the hardest, even for professionals and for anybody. It's when am I going to feel or kind of get back to who I felt I was or how I was doing before. And usually when psychosis with acute symptom versus other things or the period before is that usually you'll see a breach of functioning. Say, when you have symptoms, you will have difficulty maintaining what you're doing, whether it's work, it's school, and everything. So for us also, that's a big factor when we assess, is there any breach of functioning, and that will determine also, because we're in an intensive program. When we come in, we can be there many times a week, or we're very intensive at the beginning with the idea of offering a variety of support. But yes, it's harder, and it's sometimes when you have someone who does. For example, we get a lot of referrals from the hospital, of course, or the emergency room. And when you look back and you do the history, so you can notice that there were some red flags, or most of those symptoms, for example, which are more the negative symptoms that were at play, but it was hard to know because, it's insidious. Can you say that in English?
Yeah,
insidious. Yes. So sometimes it's not easy to differentiate what we could be referring to at that point. So, yes. Yes.
And I think too, because obviously you're part of the hospital, so you're aware that you deal with the diversity of different cultures, right?
Yes.
So for us here, a lot of times what we have to assess first is that, sometimes if they're having hallucinations or whatever, we have to, because we have a culture here of spiritual, ways of dealing with our own situations, and so we always have to check that out first. We make sure that we always have them assessed if that's not, and so that sometimes maybe at your hospital, maybe that too could be a referral to us back first, and saying that, we have this client that's, experiencing this. Is that something that we could, also help with in that sense? Because sometimes that's what happens is then they medicate the youth, and yet it was, you know what I mean?
Yes.
Kind of a wrong prescription.
Yes. That's a challenge. Yes, as you said, there are different communities, different cultural backgrounds, different beliefs also, which will impact on the treatment. So the importance of me being here and us, yes, we work for the SISMO, yes, we're a specialized program in psychosis, but your experience and the culture and the traditional healing that, for example, are available here, or the understanding of the different beliefs and culture is important for us to take into account, because yes, if it's something that is commonly known here in the community in terms of beliefs, we need to know whether that's an hallucination, for example, or a delusion. So it's working together to have a better understanding of the community so that we can properly treat the situation and not necessarily jump to the conclusion that it's psychotic. See?
I think what you said is, when someone, a dead person, can speak to you. See, our culture that happens.
Yes.
Right? So that's where it would have to be.
Yeah, when I said that, I said, I'm sure I'm going to get a question on that. Because we've had a few, I don't like the word patient, client, and I don't like that either, but a few of our youth that we follow that are from the community, and that's why our program is geared also to work a lot with family members or friends or people that are close to the youth, so that we have a better understanding of what, what was there also before versus what could be associated with something that is psychotic. So we refer to family members. So does that make sense for you? Is that what's the versus what is not? It goes beyond what the beliefs were before. We've had the moms and dads say, okay, that's normal for my son to say this, but this is not what we believe in the community here. So it's working together to understand, and we don't want to take away who the person is. There are different people from different countries also. The way they see mental health is very different from here. The way to treat mental health is very different. So we have to kind of learn more about it and be educated ourselves also, so that we don't make mistakes in understanding how we should respond to it. So, yeah. So, and there's a team also in Montreal. Also, I don't have the name now, but they also are there also for the cultural psychiatric, but services for different cultural communities. So we've had patients that we've referred there also to help us out, because it was difficult for us to know. So, yeah.
Because I'm a mental health first aid trainer.
Okay.
And that's one of the things that comes up, is that even though, like there's like standard Western treatment for psychotic episodes, like that, Ganawagi, we're taking things into account that standard Western doesn't always fit.
Yeah.
With what we're doing,
Mm-hmm.
And that, like in our history, in our past, people with, mental illness didn't see it necessarily, it wasn't seen as illness.
Yes.
So much as it made them different, but it made them special.
Mm-hmm.
You know what I mean?
Mm-hmm.
And so, like we bring up a lot, and a lot of our trainings are tailored to meet different needs.
Yes.
Like that.
And yeah.
That's what I understand, like this is for as well. But I also understand that, the earlier that you get in there, because every psychotic episode creates a deficit.
Yes.
So if you can get in there as early as possible to alleviate the psychotic episode, then the outcomes are better.
Definitely, because that's why also our team, or because there's PEP teams now everywhere around. So the idea that we are available and accessible quickly is that the longer the person experiences the symptoms, the harder it will be for the recuperation afterwards. So and of course, yes, with a lot of our youths, the idea of medication, for example, but it's really, if you look at it, like psychosis is a chemical imbalance in the brain. So you have neurotransmitters, and there is a bunch of dopamine that's coming in. So what that means is that there is chemicals, so it's biological. So the medication allows the neurotransmitters to get back to their normal level of function, if I say that, if I can say that like simply. So we say to clients sometimes, if you have diabetes, if you don't treat the diabetes, you might end up having more severe consequences on your body and on your health. So when you treat diabetes, you treat it with medication and with other things that you do, such as changing your the way you eat, changing some of your habits. But it's the same thing with psychosis. And oftentimes, the clients we work with, c'est pas visible. It's not as if you have a broken arm, you see it, it's broken, it hurts. When you have psychosis, you develop an understanding of what you're going on, and you're convinced oftentimes, because it's hard to differentiate. And to differentiate what's real versus what's not. And for them, it is real. As I say oftentimes to some parents, don't tell them that they're not hearing the voices. They are hearing the voices. See? But it's hard and it's scary. So when they explain that there are a bunch of people organizing things against them to hurt them, they do believe it. They are convinced that this is happening. And with the emotions that come with it, it's scary to think that if you go out, people are able to read your mind or to see what you're doing. So it's very scary. So say, as much as, so of course, treating psychosis, there's a big part at the beginning, certainly in terms of the treatment with medication, because a lot of the work then that you want to do, you can't do if the person is, if they're disorganized in their thoughts, in their ability to process information, their judgment and everything. So yes, there's a part of that. There's a big part of that. And then comes into play all the psychosocial help that we can offer. And sometimes people say, how do you treat it? They say, yeah, that medication, but it's as you treat a lot of other illnesses where it's a focus, a combination of, yes, medication, but lifestyle, basic stuff, you know, how you sleep. The sleep is something very important in psychosis. Oftentimes, people who experience an acute psychotic episode, if you look back the days before, there were lack of sleep, the inability to sleep, so periods of days or long periods of time where you don't sleep. So at the beginning, it's basic. How much time you sleep, your habits, how you're eating, how you're taking care of your basic needs, in addition to the medication and resting. And it might be, sometimes we say to try to put an image to it, your brain is on fire. Your brain is suffering, your brain is on fire, so we need to help try to stop that fire. So that sometimes, and it kind of resonates to them. There's a rush of dopamine, there's like a crisis going on, and we need to reestablish things so that you're able to process information and to process things a bit better. So, but it is hard. And then comes into play, as you said, that's when also then you can start looking at afterwards other traditional healing processes that will resonate better to them than other things that we might propose to other people, say to some community members or some people outside of the community, for example. So yes.
So would it be safe to say that 92% of the population is dealing with some sort of psychosis issue in the terms of believing what is real and what isn't real, given the context that social media portrays these ideal things, and we bring into our communities and our homes, and we identify it as this is real because I got it from Instagram, this is real because I got it from Twitter, Facebook.
But that's why you have to be very cautious sometimes. When someone, example, if you go on social media, if you go on internet, you read about CIA, you will find articles that tell you that the CIA can spy on people, or even now with I have colleagues that put on their computer a post-it so that the camera is not on all the time. Does that mean that they're psychotic? No. Our job is to try to go further and go beyond just the first perception or the information that was given to us. So sometimes people call to make a referral. Okay, but did you ask why they're talking about this? Did you ask? But the person is able to, has a certain autocritique judgment or an ability to criticize it. Someone that is convinced beyond reasonable and there's nothing you can move around it and it's really fixated, that's where then it's a bit harder to, that we might be more inclined to think that it might be something in terms of a psychotic disorder. I don't know if I'm making things a bit clearer around that, but it's, so we don't just stay at the first level. You have to kind of, to me, I can have beliefs that you don't have, but we could have a discussion about it and kind of say, try to look at what's the different ideas around a subject, for example. I can be very rigid about it, but does it mean that it affects my level of functioning? Like, for example, if I believe that I'm followed, or do I stop going out? Do I stop going to work? Am I like talking about this all the time? Is it interfering in my level of functioning that is preventing me from being able to live normally my life? These are certain things that we take into account to try to help us out. But it's a very good observation. I'm trying to think, I think a colleague of mine at some point was saying, you know, I went to do my income tax and my notary talked for about an hour about how the government is doing this and this and this and this. I mean, see, so he had beliefs and had ideas about a subject, but so he wasn't psychotic, I don't think so. But c'est compliqué. It is complex, definitely. And so we try to do our best to, and the idea, yeah, well, so we try to do our best to try to see what belongs to what in the best of our capacities. But I don't know if it's kind of in the direction you were going.
All kinds of more doors of opportunity on that.
Yes. So usually our program is geared for we usually get involved for about 3 years. The idea being that it's a process of readaptation. As I said, the beginning is more the medical treatment and everything, and everybody is followed by a case manager, so a worker that will be hopefully assuring the follow-up for that period of 3 years. We have, of course, an adult psychiatrist in our team that works in the clinic in Châteauguay. So we do oftentimes the first contact with the person who will make the referral, or with the youth that is being referred to us, to do more of a detecting and getting a bit more information to see if it seems to be something for us. And then we have the psychiatrist who does the evaluation. Sometimes after the psychiatric evaluation, it's deemed that it's not necessarily for the program, for the PEP program, so they're referred back to other services that are available in the community. But oftentimes nowadays, when we have someone and I see them and I say to the doctor, oh, no, I think we need to get involved and be on board quickly. I think I'm getting better after 5 years. So yeah, so sometimes people will refer to us also, and I say, no, I don't think it's up to us at this point. So try to get more info. I can make suggestions and everything, but the idea is to work together ultimately. And it doesn't mean if someone calls me and we say, not yet for us, or doesn't mean that in a month or 2 months there might not. We don't have any pretension of knowing what the future holds for everybody. But yeah, that's a bit. So there's no forms that you guys need to fill out. It's just calling us. If you have evaluations and the client agrees for you to send it out to us, you can send it out. Anybody can call. Clients can call themselves. Family members can call us. Schools. So they can call and inquire. And sometimes, of course, when we're dealing with psychosis, oftentimes one of the symptoms is not recognizing that we might be experiencing psychotic symptoms. So that's a challenge. Usually it's a clientele that's not necessarily voluntary or wants services, and our program is geared to reach out rather than them having to reach out to us. So that's why we're very flexible and we try to adapt. So, and we don't expect people to say, yes, I'd love to be followed by your team because I'd like to do this with my life. We'll help them figure out what they want to do, but ultimately we try to work with families when they call us, to see how we can connect, so that we can at least have a first contact and try to do some education with them in terms of what we might perceive as what's going on, for example. So,
what are the ages?
It's 12 to 35.
12 to 35.
Say a challenge in terms of child psychiatry is most likely would be the Montreal Children's Hospital. They have the PEP team there also. So if they are under 18, they might be referred to the Montreal Children's Hospital. But over 18, it's really in the office in Châteauguay. But as again, we come out, we go to the houses if they're okay with that. Some clients don't want us to go to their homes, so they can come to the office, or we can go take a coffee, or we can find different ways of being in an environment that makes them feel comfortable. So. We try to include families from the beginning, and of course other professionals that are involved, but we try to contact families quickly within the process to also, we have groups also with our programs, where one of which is for family members or members of the family or the community that are a significant other. So where we talk about what we do, we talk about what is psychosis, what attitude to adopt, what to do or not to do with as much as possible, or just a safe place for them also to be able to talk with other family members that are experiencing something similar. So the idea of the program, because it's a lot for a case manager, a caseworker to we're involved in various spheres of their lives, whether if it's to regulate the financial situation, do education, get them back to school, for example. So families, we cannot neglect them. More and more, it's important that they're included as much as we can, considering confidentiality and everything. So, but given info, that's not something, we're not breaking confidentiality. When you educate someone on what is mental illness and general information, so that's why we have these groups. It's a work in progress, but it's available now. So we do that also. And we have in terms of mental health, the important is physical activity is really important. So right now we have a walk. We go for a walk every week with some of our clients, and we have a gym in Châteauguay that we receive donations, so we're able to go to the gym once a week also for the clients who want to come. So we try to do that, and we have groups also with education. Yes.
Well, you sort of answered the question a little bit already, but say it's an outside organization that, like a school, for example, that calls, they're concerned about a student, they call you. So do they call you and then you contact the family, or do you suggest they contact the family first to let them know like give them your resource, or? Well,
what we ask is that they know that they've called us. Let's say we don't want but we don't want a consent form and something. So basically they need to know. So oftentimes what I say, just let them know you're concerned about some of the manifestations, some of the symptoms, and you call the team that might be more specialized to help understand what's going on. So yes, they need to be advised. Sometimes, who is it that called me the other day and said, okay, I think there are symptoms of psychosis, but did you tell the client that you called us? So I'm not going to call someone who wasn't advised first. So they need to know, at least. They don't have to start saying, I think you're psychotic and you suffer from schizophrenia, or let's bring it back to a notch before where you seem to be in distress because of what you're experiencing. It seems to be stressful, it seems to affect how you're doing, so why don't you meet this team that might be able to help understand what's going on? So.
And same for the family, right?
Oui.
You're dealing with minors, so like the same thing where it would be like 14 and under, you would have to, because 14 and up, they can consent to their own medical health care and all that, so obviously you have to inform the families that you call or plan on calling.
Yeah, definitely.
So for the gym and walking,
Yeah.
you also have a team for like a nutritionist that is part of your team, that they would be part of?
That's a great question. In our team, we have a posting for a nurse. So in our team, we have social workers, a nurse, we have a psychoeducator. We used to have an occupational therapist, so there was a variety of different professionals with different expertise, even though we work individually with in case management. But so it's mostly the nurse that will play the role of that, because yes, also with medication there can be side effects associated with antipsychotic treatment. So there's risk to the what the other problems that can develop from that. So yes, there's no nutritionist. If someone has like more serious problems in terms of nutrition, we might look into, can they be referred to a nutritionist, whether it be at the CLSC or in private or whatever. So, but there is always a consideration. All the workers will talk a lot about education on what you eat and activities and the physical aspects. We try more and more also when they have a family doctor to be involved with the family doctor, or at least let them know that we're here and work in collaboration if there are any medical problems that stem from that, or for whether they're associated with the treatment or whether they're there before or will arrive in the future. So, yes.
Yeah, there's a lot, like some of the clients that we know that are on this medication, and then they put on a lot of weight because then they go to more processed food because they crave that. So I a lot of times talk a lot about how important nutrition is when
Definitely. In French, c'est les troubles métaboliques, metabolic trouble that can be associated with it. So they're very strong consideration for that. And so definitely, and our psychiatrist who works mostly with patients who are treated with antipsychotic, we will always try to have the medication that has the less side effects, let's say, and the lower dose as possible. So yes, at the beginning, see, sometimes some people will feel, we try different things and I'm not a lab rat and I don't like that. I understand. Unfortunately, it's not all white or all, so there's gray zones. So in 5 years, I've seen it. See, the idea is that you are, if you can diminish it as much as you can, depending on the evolution. So that's something that is quite taken in consideration. And they will, if there's they will try to avoid as much as possible the ones that we clearly know that have like very important impact on the weight gain, for example. So that's always taken in consideration. It's not taken lightly at all, because then you have other problems that can come into play. So, yes.
Something just came to my mind as you were naming the members of your team.
Yeah.
It's very similar to what the interdisciplinary team that's taking part in diagnosing FASD, fetal alcohol spectrum disorder.
Okay.
So it's just like, because you need a multidisciplinary team to diagnose a child, which is like a social worker, psychoeducation, a family doctor. So it's like you're halfway there to having that team. Like, just a thought,
yeah.
Because it's like maybe that's an underlying misdiagnosis with the person, and because that's an issue with people with FASD is like a chronic poor fit throughout their life that they haven't gotten accommodations in the care, and then could lead to health issues and further problems. So it's just a thought that came to my mind.
It's very interesting, definitely. Yes.
Yeah, I think a lot, for me, what popped to my head was eating disorders. Eating and feeding disorders, especially with like anorexia, how they have like dysmorphia about what they actually look like. So it can actually be seen as a psychotic, psychotic episode when they're trying to, like trying to deal with it.
Yes.
And I know that like eating and feeding disorders are very hard to treat. So, because they're taking it from that way. But this is kind of like covering like everything, and the crux is the psychosis.
Yes. Yes.
So you have to have multidisciplinary, at least an open mind.
Definitely. See, I think it's for me. I'm sold completely. I've done a lot of things as a social worker over time, and I love this program. It's always, I think we always have experience to develop and ameliorate also our ability to do evaluations. But the idea being is that, what they're asking us is that we assess the situation from the beginning. We assess the needs of the youth, but also his family members, try to get as much information as possible so that eventually we are able to address other issues that stem. Yes, it's the psychosis, as you said, that brings us in, but it's important to have a more global view of everything.
Yeah, exactly.
You were talking about manic before, but ultimately, the whole point also is we never come up with a diagnosis usually at the beginning of the treatment. So they come in for a first episode of psychosis. So sometimes people will say, do I suffer from schizophrenia? So it's hard to say how the evolution of the situation, if there will be a diagnosis that will be there. So some people would experience first episode of psychosis in the context of a depression, and they can have, psychotic symptoms. It can be an introduction to bipolar disorder, and then in the manic state, they do have symptoms of psychosis, for example. But some people will experience a first episode of psychosis and will, with proper treatment, so we're talking about medication. I talked about risk factors before, but factors of protection. So the choices you make, we haven't even talked about substance abuse, but so changes you make in your lifestyle, how you deal with stress, anxiety and everything, all of that together. We have some clients that have never experienced other episodes of psychosis. So it was one episode, and with treatment with all the psychosocial services, and even in time we've diminished the medication to the point where they ended up with no medication. Some other people in time will have maybe a diagnosis, but they can live a nice and fully life, whatever the diagnosis is, based if the treatment, say, of course, is geared in the right direction, with sometimes periods that are more difficult, but and some people it's drug-induced also in terms of psychosis. So that's something that we also monitor to kind of find out a bit how things evolve in the future. So, of course, we do a lot of work around substance abuse and, réduire les méfaits. C'est ça, having habits or, working on that so that it can be addressed. We address that like a lot in our follow-ups in terms of addiction, so.
And I think just for that, like a lot of times the question is very specific to, drugs or alcohol, but a lot of times like they don't ask the question about food, because food, is also an addiction that is, can also be part of chemical imbalance in your brain. So sometimes that question is often misguided and into the importance of that.
Yes. Any questions? I don't know if I was kind of I went into the.
No, I think it's pretty clear. Yeah, I think what we more like needed to do the more of a question and answer rather than just.
Yeah.
Because I think when I'm talking, I'm listening to you and I'm just thinking about different clients in my head. That
yes.
That, and then how does that? Because I mean, for us, we never had this pep team. Like it's very recent for us, so it's like a breath of like fresh air, because we've struggled so long trying different, trying to gather together maybe a team that could offer this service, and now we have this actual team that we can refer a client that we just know that we can share that this is what we've done, this is how far we can take, like obviously for Cody and I are in addiction, so we take the clients to as far as we think that they can go, and then we can refer them to the team.
And sometimes we can work together because, as I said before, we address the substance abuse within our follow-ups, but sometimes it's hard for a case manager to be dealing with everything, let's say. And so for some clients, we try to avoid having too many people or else they will give up on the follow-up like au complet. Oh, sorry for my French. But see, like for people like that are not from Ganawagi, we work with Le Virage aussi. So if we have a youth that lives here, that we get involved, doesn't mean you guys have to go away. We can work together and we can kind of determine who's going to work on what and how, so that we can offer the best quality of services possible. So this way you don't have to deal yourselves also with everything. Say if you're trying to work on reducing the negative impacts of the drug use, for example, but you're coping with the symptoms of psychosis. So we try to see what's the best way to go with the best course of action. So, yeah, I don't know if it makes sense.
Yeah, that's when we deal with the doctor. Like right now, when we get a hold of the doctor is like almost impossible. So, then to get a hold of the psychiatrist is impossible. Is to get, because it's like, it's just, everybody is maxed, right? Everyone has other, situations. So when, again, like you said, when you're left, kind of carrying, the bag, and you feel like with your discipline, like you've taken the client to as far as they can go, but then you need that other, support. And we don't, we've never had, a psychiatric team that we were able to refer our clients to, and it was always had to go through the hospital, go through emergency. If they're not psychotic in the moment, they're, if you have patience enough to wait 24 hours in the hospital, then they leave, right?
Mm-hmm.
So that's always that.
And if someone is presenting, as I described from the beginning, psychotic symptoms, okay, and has a breach of functioning and is suffering from it, yes, of course, people are, in the past, the reaction is to, the only option oftentimes is the emergency room. We're not an emergency program in the sense that I don't work 24 hours a day, but I work from Mondays to Friday. But if they don't want to go to the hospital, but they have all the symptoms, all the criteria for follow-up, they can be referred to us. The goal, we often say to our youth, we want to keep you as further as possible from the hospital. But sometimes, in the process, sometimes we do end up in the hospital, but it's done, hopefully, I'm talking about best case scenario, in a fashion that the person understands why, agrees, and understands that there are more advantages to it than disadvantages. So we try as much as possible to keep people in the community with having more intensive services. So yes, that's an option. We say to police officers, if you intervene one night with someone that seems to have psychotic symptoms, they can be referred to us. We can see if that fits with our program. It doesn't have to go through the hospital to go through us. So, yeah. If he's psychotic or she's psychotic. Yeah, because the challenge for me, I've been there from day one. Initially we were kind of going to see everybody. Sometimes they present one symptoms, but you have to put it in context. I hear voices at night when I go to bed. Not to say that it might not be scary or involves that there's something going on and there is a mental health issue or psychological issues, but just that in itself, there can be different explanations to it. So that in itself alone, if the person is going to school or doing their stuff, and it doesn't mean we don't necessarily will get involved in something. We need a variety of symptoms and with impacts on the level of functioning to say we're going to jump in and start being involved. I don't know if it makes sense, but yeah. Because initially we were seeing a lot of people, and then we go meet them. It's like, oh my God, I don't know. It's something very different than psychosis. So. Yeah. And just also, that's a bit because ultimately we're geared just with psychosis, but at the SISMO there are other programs that are community-based, let's say. Every time I have presentation at a community, I say my director will say, oh my God, you're looking for clients to come in. No, but there are other programs. There's we were called PEP, but there's the CIV and the SIM. Basically, we're geared just for psychosis, but there's le CIV, suivi d'intensité variable, so variable follow-up in the community. It's not just for psychotic disorders, it's for other mental health issues, and it's 18 and up, so it doesn't stop at 35. That offer community-based services also, so sometimes that could be something that could be of consideration also. Voilà. Ça ressemble à ça. Puis just for, on the website, the one that you see in the back here, I'll give you the pamphlet, but it's called Referoscope, www.referoscope. It's really an internet site where it's a questionnaire that can be filled out either by a professional, a family member, a youth itself, where they have a bunch of questions that help you detect if we're looking at possible symptoms of psychosis. And it gives you recommendations when you fill out the questionnaire. And there's a lot of videos also with someone describing experiences of psychosis, whether it be hallucinations, méfiance, when you're, méfiant, how do you say that in English again? When you don't trust people.
Paranoia?
Yeah, when there's a lot of paranoia. So there are different, sorry for my words in English, but there's different videos also. So that's quite interesting also. Sometimes you can have see anybody look at it, whether it be professional or clients. So that's very interesting as a video. There's also a site, it's called Your Mind Matters also. There's a lot of videos of people who have experienced psychosis and have gone through the treatment or worked with a PEP team and how it affected their lives or what the outcome was. So it's really interesting. So don't hesitate to go and look. So you have here on our platforms, you have our phone number here to reach us. And so don't hesitate to give us a call if you have any questions or refer people.
All right, so again, Genvieve, I'd like to thank you.
Thank
and
you.
I'd like to thank you for everyone for coming to experience Tehontatro for this month.